My name is Mark Cleaver. I'm at the University of Wisconsin at Madison, and I'm going to talk about the basics of carotid sonography. I'm going to discuss the basics of carotid sonography, and in particular, the Doppler and grayscale evaluation of plaque. I'd like to acknowledge Leslie Scout from Yale University for additional information that she has provided. In this lecture, I'll talk first about the technique of carotid sonography, something about the grayscale assessment of plaque and the vessel wall, spectral Doppler analysis, color Doppler, and end with some pearls and pitfalls. First, the technique. In general, we use a high-frequency transducer in the 5 to 12 megahertz range with the patient supine and the head on a bolster with the chin up. I like to turn the chin away from the side at which I'm scanning to expose the carotid artery to maximum advantage. The examiner is usually to the side, but some people prefer to examine from the head of the bed. Here's an example of how most people do it. The transducer is placed on the neck with the patient sitting at the side of the patient. The success of the technique depends on several factors, but it is most important that the patient can cooperate in some way. If a patient has had perhaps an acute brain injury, they may become agitated or demented and be unable to cooperate. Further, if they were to fall asleep and to snore, then useful information is difficult to obtain. The grayscale of assessment hinges on several things. One is, what is the plaque characteristics? What's the symmetry of the plaque? What are some of the surface features of the plaque? And then finally, percent stenosis. To remind you that the wall of the carotid artery should be thin. In many Western countries, you will see what is known as intimomedial thickening, which can be up to 1.2 millimeters and still be normal. Exceeding that threshold is considered abnormal. This is an example of the intimomedial thickening that I'm describing. At times, instead of focal plaque, you'll see a concentric thickening of the vessel wall, and there are several things that can give this appearance: radiation, Tortuous arteritis, temporal arteritis, and fibromuscular dysplasia. Frequently, this is seen in the common carotid artery. You can see in this image the wall thickening here that surrounds the carotid artery. In this case, the patient had Tortuous arteritis, which involves the major vessels from the aorta. Here's an example of fibromuscular dysplasia. Again, this is the carotid artery, and you see the wall thickening. Here is the classic appearance on angiography, the beaded appearance of the internal carotid artery in this case. So plaque, focal plaque, can have different echogenicities. They can be homogeneous or heterogeneous. In general, heterogeneous plaque is associated with instability because that suggests the presence of intraplaque hemorrhage. Here is the carotid artery here. You can see this plaque protruding into the lumen of the vessel, and the low echogenicity center indicating intraplaque hemorrhage and plaque instability. In general, hard plaque is more stable than soft plaque, and by hard plaque I mean plaque that has a high level of calcification. So this would be an example of hard plaque, and you can see the shadowing associated with that calcification posterior to the plaque. One thing about hard plaque is that the shadowing will make segments of the vessel inaccessible to Doppler interrogation. If the sound waves are not reaching it to create a grayscale image, neither are they reaching it to create Doppler images. So no grayscale, no Doppler. People in the field, if you are trying to insunate that segment of the carotid, frequently find it helpful to insunate the vessel from a different angle, or a different perspective. The surface characteristics of the plaque has been identified as an independent stroke risk. The surface characteristics are, however, difficult to identify with certainty and to characterize in some cases. But as a rule, smooth plaque is more stable than irregular plaque, and irregular plaque is the kind of plaque that can give off emboli and result in embolic strokes. Ulceration is seen as a deep pit or break in the plaque, and this can be difficult to identify. Here is an example of a plaque ulceration. Here is the plaque. Here is the flow into the heart of the plaque, indicating an ulceration. Frequently, in the presence of ulceration or plaque irregularity, you will see eddy currents or abnormal or unusual patterns of blood flow. Here's a color Doppler image with 3 different sampling sites, 1, 2, and 3. And you can see that both the direction and the character of flow changes radically as we sample different portions of this vascular segment. The grayscale assessment is usually done both in transverse and longitudinal planes. It's important to identify certain landmarks, notably the carotid bulb and the carotid bifurcation, and to identify the individual components, the common carotid, internal carotid, and external carotid arteries. When we do see plaque, we often measure a percent diameter and assess for area stenosis. To remind you a bit about how these things are typically reported, usually stenoses are reported in terms of a percent diameter stenosis, which is not the same as cross-sectional area reduction, because a 50% diameter stenosis corresponds to about a 70% area reduction. And similarly, a 70% diameter reduction corresponds to critical stenosis or severely flow-limiting lesion. This type of stenosis is typically measured in the transverse plane, but beware of asymmetric or soft anechoic plaque, which can be missed. In general, power Doppler, if available, can define the margins of the plaque with greater precision than color Doppler. When you do measure the luminal diameter narrowing, typically there's 2 ways of doing it. Most programs do it using what's called the NASCET criteria. That's an acronym of N-A-S-C-E-T. And the NASCET criteria is based on a endarterectomy trial, the North American stroke treatment and endarterectomy trial. And it's measured by measuring the luminal diameter of the vessel at the stenosis and dividing that by the diameter of the normal downstream ICA. So by NASCET criteria, the luminal stenosis would be measured as a ratio of the diameter A over the diameter C. Some people have embraced the concept of measuring what's known as a residual lumen at the stenosis. In general, the diameter of the ICA is 5 to 6 millimeters, and if there is a residual luminal diameter of 2 millimeters or less, then the lesion is in the surgical range, that is, the greater than 70% diameter reduction. Spectral Doppler. In a normal and unaffected vessel, the flow within the carotid artery is known as laminar. This is a even parabolic flow, you can see the diagram here, with a relatively narrow range of velocities. And this narrow frequency spectrum is illustrated in the Doppler waveform as a narrow envelope of velocities that enclose what's sometimes called the acoustic window or a spectral window here, an area of relatively little blood flow here in the lower frequency ranges. So it's an envelope of higher frequencies. If, however, you don't see parabolic or laminar flow, you are in a condition known as spectral broadening. This indicates disturbed flow with a larger range of velocities, and again a filling in of this spectral or acoustic window, because now we have representative blood cells moving at different velocities from baseline all the way to the peak envelope of velocities. Graphically, it's illustrated as a filling in of the spectral waveform here, and also as multiple color flurries on color Doppler imaging. If you do see spectral broadening, the most common cause would be focal atherosclerosis, but there are other things that can give you the same result, namely the disturbed flow that results from an arteriovenous fistula, disturbed flow at an endarterectomy site, the presence of tortuous vessels, and also spectral broadening is common and normally seen in small vessels. Here's an example of an arteriovenous fistula and the spectral broadening at the sampling of the fistula, where you can see this multiple levels of velocity being represented here on the spectral waveform. Velocities and the waveform character can change radically at the endarterectomy site. Oftentimes this has to do with decreased vascular compliance, but the presence of both elevated velocities and high peak systolic velocities and a spectral broadening phenomenon is common at the site of prior surgery. Tortuous vessels are notorious for causing spectral broadening. Oftentimes, particularly in older patients, you'll see vessels that make abrupt turns, and as you can see on this color image, at the abrupt turns, the flow dynamics are changing rapidly. Here's an example of sampling at the prior to a turn and then after the turn, and you can see that the acoustic or spectral window is filled in after the turn because we have a broadening of the velocity spectrum, or this spectral broadening that I'm describing. Not all spectral broadening is easy to identify. There are pitfalls in the identification of spectral broadening. Specifically, if the gain setting of the Doppler is not set correctly, you can fill in that acoustic or spectral window artifactually. Secondly, if you don't center your sampling gate within the lumen of the vessel, but rather have it eccentric in the lumen, say close to the wall, you can get spectral broadening on the basis of detected wall motion of the vessel. And finally, this can be normal when the vessel abruptly changes caliber, as it does as it enters the carotid bulb. Here's an example of wall motion. You can see that my range gate is opened up widely to encompass both the center stream and the periphery of the vessel, as well as the wall itself, and you can see a lot of spectral broadening here. If you sample outside the center stream, here's center stream sampling, you do have an acoustic or spectral window. If you sample closer to the wall, you'll get the spectral broadening phenomenon. Now we'll talk a little bit about spectral Doppler criteria in the diagnosis of carotid stenosis. There are different parameters that are used, the most common being peak systolic velocity and diastolic velocity, the ICA-CCA ratio both in the peak systole and in diastole, and then finally the presence or absence of spectral broadening. There is a useful reference that where this criteria is tabulated. I refer you to two publications of this journal, of this article, both in Radiology and in Ultrasound Quarterly. It is a consensus conference that was produced by the Society of Radiologists in Ultrasound. The criteria that was agreed upon at that consensus conference is like this. A diameter stenosis in the ICA of less than 50%, which is to say a non-significant stenosis, is identified when the velocity, the peak systolic velocity, is less than 125 centimeters per second, the end diastolic velocity is less than 40 centimeters per second, and the ICA-CCA ratio at peak systole is less than 2. For diameter stenosis in the 50 to 69% range, which is a borderline range that exists between non-significant stenosis and stenosis that is non-surgical, is identified with a peak systolic velocity in the 125 to 230 centimeters per second range and end diastolic velocity in the 40 to 100 centimeters per second range, and an ICA-CCA peak systolic ratio between 2 and 4. Then, diameter stenosis that would be considered in the surgical range or critical stenosis, that is greater than 70%, is identified by peak systolic velocities exceeding 230 centimeters per second and end diastolic velocity exceeding 100 centimeters per second, an ICA-CCA peak systolic ratio that exceeds 4. It is interesting to note that though you may not have the criteria immediately in front of you, but you can make a general estimate of degree of stenosis, remembering that the peak systolic velocity less than 125 is insignificant, but if you double that factor to, let's say, around 250, 230, then you're in the area of critical stenosis. Similarly, you don't get into the area of significant stenosis until about 40 centimeters per second, and if you double that, that's about 80 or 100 centimeters per second, and you're in the range of critical stenosis. And similarly, the ICA-CCA ratio starts to become significant at 2 and becomes critically significant at 4. So if you remember 125, 40, and 2, you can remember really the essence of this table. Now remember, though, that you have to look at everything on the image. It's not enough simply to look at numbers. It's very important to look both at the color and the grayscale, because there will be a high-grade stenosis above which the flow is limited and the velocity will decrease. And here this chart shows it. As the diameter stenosis gets more severe, velocity increases because of that jet effect at the stenosis, but then will drop off precipitously when that stenosis starts to become occlusive. So don't simply look at the peak systolic velocity and make your determination from that alone. That would be a mistake. All right, now to talk about some of the color Doppler factors to consider in the assessment of carotid stenosis. First of all, we'll talk about detection of luminal abnormalities, the presence or absence of helical flow and boundary layer separation, and finally some limitations of the carotid Doppler analysis. First of all, the intraluminal band are sometimes seen in the performance of carotid Doppler, and a band that crosses the lumen of the carotid artery can result from basically 3 sources, the most common being a free edge of atherosclerotic plaque. It can also indicate dissection or the presence of fibromuscular dysplasia and luminal webs. This is an example of a free edge of atherosclerotic plaque that is waving within the lumen, and we've done an M mode showing the motion of that free edge here. Dissections, carotid and arterial dissections, are usually seen as thin septations or bands, as shown here in this carotid artery, that shows different flow profiles on either side. In other words, if you put a spectral Doppler cursor on this side of the band or septation, you will get a different appearance to that waveform than you will see on the other side. In general, acute dissections can be very difficult to see because it is simply a very thin layer of intima that's raised in the lumen. In general, these become more visible as fibrin deposits on the dissection, and the dissection becomes chronic. Here is an example of another dissection, quite difficult to see on grayscale, but on color Doppler, the presence of that septation becomes more visible, and if you were to sample on either side, you would get different flow profiles. Another example, now this is a chronic plaque. You can see that this is more echogenic here. And here it is on longitudinal, then that, and you can see one of the flow profiles there. And if you sample it, you often get this, what some people call the stump thump phenomenon. Anyway, short, percussive, thumping waveform here, which is both muted and low velocity. Fibromuscular dysplasia one of the manifestations of fibromuscular dysplasia is a web that is seen protruding into the lumen. And this is an example of a young woman who had a stroke with no history of trauma or disease. And so if you see this in a young patient, you have to think about the presence of fibromuscular dysplasia. Helical flow is a phenomenon that's commonly seen and normally seen in many patients. This is flow that is helical in the sense that it has two components of motion. It is moving forward and it is moving in a circular pattern within the vessel lumen. That's demonstrated here on these transverse images. In this case, flow is going in a clockwise direction. You can see that, but it is also moving, of course, cephalad towards the head. If you angle angle your transducer to demonstrate it, so it is going in two different directions. It's going in a circular motion, and it is going forward both in that helical pattern. If you sample the helical flow and longitudinal on either side of the vessel, you'll get, you can pick up that component of circular flow. It will look like it's going away from you at one point, one portion of the vessel, and on the opposite side, it'll look like it's coming towards you, which in fact it is. It's not uncommon to see flow reversal, particularly around the bulb. This is a phenomenon that some people refer to as boundary layer separation, and it is a consequence of the fact that as a laminar flow enters a capacious area or a suddenly widened area, such as the capacious or the enlarged bulb, you will get flow reversal at the periphery of the vessel as that flow at the periphery is flowed to the point of flow reversal. Some people have so much as suggested that the absence of this boundary layer separation phenomenon at the carotid bulb itself indicates the presence of disease at this location. Here's an example of that. Here's the color Doppler. You can see this is true flow reversal and depicted here as flow below the baseline in this spectral Doppler tracing. I'll conclude the lecture with a series of pitfalls and pearls. First of all, there can be some variability of Doppler measurement based on technique, instrument variability, in other words, one machine to another, physiologic differences between patients, and finally, vessel and plaque morphology. There is quite a lot of controversy about the need for a uniform angle from one study to another. Suffice it to say that many people insist that the color Doppler angle should be the same for serial studies, and in general, those people advocate a 60-degree angle of incination. That the angle matters is indisputable. If you measure here and you change your angle, you can get a change from 140 to 195 centimeters per second, so that is quite a large change just by changing the angle of incination. So you want to keep that as uniform as you can. Remember that the angle of incination radically affects the reliability of the measurement. Measurements become much more variable when the Doppler angle exceeds 60 degrees. So all measurements of carotid velocity elevation or velocities should be obtained at 60 degrees angle of incination or less. There has been some controversy about whether the Doppler angle should be parallel to the wall or parallel to the jet, remembering that the plaque, of course, is frequently asymmetric and creates jets that are not parallel to the wall, but rather directed towards the wall. And the consensus is that the Doppler angle should always be measured parallel to the wall. Remember that gain can cause problems. Here's an example of two plaques. This one looks like it has intraplaque hemorrhage, but if you turn up the plaque even a little bit, you can see that there is quite a lot of echogenicity within the plaque, and that this is not the intraplaque hemorrhage that it appears. Sometimes the gain can be adjusted too high. This is an example of that. This is gain that is adjusted way too high, but when shown in color Doppler, what appears to be plaque is clearly not present. Finally, spectral Doppler gain can affect the measured velocity. If the gain is set too low, you can not detect some of the faster velocities within the vessels. And here, as I adjust the gain down lower, you can see that some of the faster velocities are screened out, and you get a difference of about 20 centimeters per second. There is some instrument variability. This is perhaps less than has been touted, but suffice it to say that if you do serial exams on patients, you should try to do it as much as possible on the same machine. If you use different machines, you can get some variability that's based simply on the variability between instruments. Then there are physiological differences between patients that can result in different measurements. Patients who are tachycardic or have a fast heart rate will tend to have a lower peak systolic velocity and a higher end diastolic velocity because of the lower filling of the cardiac chambers and the shortened time for the diastolic flow to decline. Patients with an exceptionally low heart rate or bradycardia will tend to have lower end diastolic velocities because the decline within the waveform is greater and the peak systolic velocities tend to be greater. Hypertension tends to result in higher peak systolic velocities. And again, if there are the presence of cardiomyopathies such that there is decreased cardiac output, in general that results in a decline in measured peak systolic velocities. This sort of decreased cardiac output is seen with cardiomyopathies and hypotension. Here's an example of this. This is a decreased peak systolic velocity measured in this case in the range of about 40 centimeters per second. In this patient with a cardiomyopathy, you can see that those effects are seen throughout the carotid system, both in the right system and the left, as well as the common carotid and the internal carotid. So the central abnormalities such as cardiac abnormalities or cardiomyopathies are seen globally through the carotid system. Cardiac abnormalities most often directly affect the absolute measure of peak systolic velocity. Using the peak systolic velocity ratio will usually compensate and give you some handle on degree stenosis. So if you have a patient with a low peak systolic velocity but with obvious plaque, I would suggest that you rely more specifically on the ICA-CCA peak systolic velocity ratio and correlate, of course, with the appearance on color and grayscale. Arrhythmias cause all sorts of problems for velocity, precision, and measurement. It is important that if you can identify a strip of several identical waveforms that you do your measurement there, either that or choose the highest peak systolic velocity seen on the strip. Some people's arrhythmias are so irregular that you won't be able to find a pattern of 3 or more consistent waveforms, and in that case, your last resort is to use the highest measured peak systolic velocity that you obtain. Furthermore, because the Doppler, the vessel is changing direction very rapidly, it's difficult to identify a correct Doppler angle. In general, peak systolic velocity tends to be overmeasured in a tortuous vessels, and so I strongly suggest that you correlate with grayscale imaging and look for focal narrowing, because peak systolic because a true stenosis should cause poststenotic turbulence. Here is an example of a true stenosis. Here both, I should say that long segment stenosis can be another source of velocity variation. As you might imagine, a long segment stenosis in this plaque will be artifactually low because of the flow limiting quality of a long segment stenosis. Tandem lesions can frequently cause aberrant waveforms. And by tandem lesions, I mean lesions that are seen both proximal and distally, and measurement in the intervening segment will give you very bizarre waveforms as the flow pattern will swirl and eddy in that isolated segment. In general, the peak systolic velocity is less than expected in the segment marginated on either side by flow-limiting lesions, tandem lesions. In some cases, if you have a high-grade stenosis on one side, that will cause velocity elevation on the other side. In some studies, the use of ratios, that is the ICA-CCA ratio, does not compensate, and the effects from one side to the other can be highly variable. So in those cases, I recommend you use grayscale measurement and color Doppler to give you a better sense of the degree of stenosis on the contralateral side, the side away from the high-grade stenosis. So this is introduction to basic carotid sonography. I talked a little bit about how the study is performed, how to assess plaque in grayscale, spectral Doppler analysis, color Doppler analysis, and then some pearls and pitfalls. In a separate lecture, I will talk about waveform analysis. Thank you.